Street, Birmingham, UK. He will present an immediate loading from single tooth to full arch. Welcome, Professor.
Okay, once again, good morning, everybody. How are you? Great. Are you ready?
Yeah.
Ready for everything? Okay, so we can start. Because in the next 3 days, we will talk about implant and oral surgery. So we will start from the basis, and then we try to increase more and more difficult case. And we will talk about standard implantology, and we will talk also specifically about immediate loading implantology. And in doing so, I want to tell you a story. I will tell you my story, like man and like oral surgeon. So starting from the man, I come from lecture. I will show you. Okay. I need the PowerPoint, but it's a strange presentation now. I'm trying to change. Can you give me the screen? So, sorry for the interruption. Come from Lecce. Lecce is a beautiful city at the extreme southeast of Italy, where I live and get my private practice. And I want to show you something about my area. It's a beautiful place. It's very, very similar to here. We do have a beautiful city, an Arabic architecture. Very powerful visual. Very famous photograph. So this is the place where I live and I stay and I have my private clinic, and it's a beautiful place, and you all are invited to come to my office or for the holiday there because it's amazing. And as I told you before, it's very similar to this country, to this area. Also because of very long domination, Arabic domination we had in the past. Anyway, I took my degree not in Lecce, but I took my degree in Modena. Modena is a very good university we do have in Italy. It's in the ranking very, very high. And Modena is also the place where the best sports cars in the world are made. Because Maserati, Lamborghini, Ferrari, they are all made in Modena. So this is my second passion, paleontology and sports car. In Modena, I took my degree and I attended a 4 one-year-long postgraduate course in implant surgery, oral surgery, periodontal surgery, and advanced implant surgery. The last but not least, in 2005, I had my postgraduate at New York University in implantology and cosmetic dentistry. And at the moment, I'm clinical coordinator and vice president for the Italian Association of New York University. I teach in Bari at the International Master in Implant and Oral Surgery, and we are also talking with the dean of this university to create a sort of joint venture with Bari University to give you the opportunity to attend International Master there in Italy. And I am associate professor in implant dentistry at the College of Medicine and Dentistry in Berlin. So now you know a little bit of my story, but this is not the important point. What is important for me is to share with you what I have in my brain and in my hand. And I hope that this can be helpful for you, for your practice. When you go back to your office, I hope that you can say, give me a good idea, I will do like that. That's my idea. And you know what is great with knowledge is that we can share what we have without losing nothing. If I teach you something to you, I don't lose nothing. If you teach something to me, you don't lose nothing. That's the power of knowledge. Maybe sometimes we look with law, it happens something like that, only with the students. So what we are going to treat and to talk during these 3 days are immediate loading and normal loading, of course, also, post-extractive immediate loading, platform shifting and one-piece implants, socket preservation, and, I'm sorry, we will talk also about complication management. So for the student, you have to think that you will always have complication with oral and implant surgery. If you don't want complication, go to the bar and drink tea. If you work, you will have complication. So the point is how to manage complication. That's the key point. You have to try to avoid, and when sometimes happen, you have to know how to manage. I know that biology is a little bit boring, but it's extremely important. And I will show you in this picture, it takes 10 minutes of concentration, all the process of osseointegration, and it will be very important. I will tell you why.
Our bones are a marvel of natural design, continuously rejuvenating to a finely balanced equilibrium of bone resorption and new bone formation. A truly miraculous structure is formed, which follows the right of the mechanical level, the trabecular bone. Sometimes, however, the unexpected happens. A drill intrudes and destroys the naturally sculpted bone. Blood vessels are torn and a major defect is created, quickly filling with blood. The titanium implant is inserted where the tooth was previously lost. At first, the only force holding the implant in place is mechanical friction. This is called primary implant stability. Osseointegration, or secondary implant stability, requires a highly complex sequence of additional biodynamic processes. This is facilitated by finely tuned communication between the main actors of wound healing, the cells. The blood immediately perfuses the surgical site, providing the cues for subsequent healing. Within seconds or minutes, ions and serum proteins such as albumin, fibrinogen, and fibronectin begin adhering to the detained surface. Next, the bleeding is stopped by blood platelets, also known as thrombocytes. When they are exposed to collagen and other proteins from the traumatized tissue of the implant surface, they aggregate and close the ruptured blood vessel. Platelets release various messenger substances or cell-to-cell communication, such as thromboxane, which promotes platelet aggregation, or PDGF, platelet-derived growth factor, which stimulates the cell division of fibroblasts. Fibrin monomers spontaneously cross-link, forming a fibrin network. The blood clot permeates the wound space, forming a provisional matrix. It also adheres to the implant surface. This blood clot has tremendous importance as a provisional matrix for subsequent bone healing processes on the implant surface. During the early stages of healing, immune cells clean the blood of the very fine bone chips, tissue debris, and oral bacteria that remain following the surgical procedure. In the first step, rapid killing from the platelets increases blood vessels' permeability. As a result, the endothelial cells move apart very slightly. On the inside of the vascular walls, endothelial cells promote the attachment of polymorphonuclear leukocytes from the bloodstream. These leukocytes, also known as PMLs, squeeze themselves through the gaps between the endothelial cells. Once they have digested the basal lamina using proteases, they are free to enter the wound. PMLs chemotactically navigate toward the wound along the molecular concentration gradient. These molecules include bacterial proteins, fibrinopeptides, and pro-inflammatory interleukins. Upon arrival, they kill bacteria through the release of reactive oxygen species. PMLs also release highly digested enzymes such as collagenase and elastase. The wound then proceeds through an uneventful healing process, or a toxic wound environment develops with elevated bacterial counts and toxic byproducts, potentially leading to wound breakdown and implant loss. PMLs can call for auxiliary support, for example, through the release of monocyte chemotactic protein, or MCP1. Macrophages respond and are the next actors to arrive on the scene. They too eliminate bacteria by phagocytosis. Tissue debris is taken up and biochemically degraded. Macrophages synthesize pro-inflammatory cytokines and proteases. Macrophages dominate during the late inflammatory phase. Using endiogenic inhibitors for digesting proteases, the so-called tooyh, macrophages help stop the random tissue destruction started by PMLs. This preserves the matrix proteins and proteoglycans in the wound, which in turn protect important growth factors. Messenger substances such as VEGF, PDGF, and FGF stimulate fibroblasts and angiogenesis, which initiate the proliferative phase. Fibroblasts appear on the third or fourth day. They migrate into the wound using a levoid movement. They synthesize the protective and stabilizing components of the extracellular matrix, such as collagen, elastin, and proteoglycans. The low oxygen concentration in the tissue affects both macrophages and endothelial cells, stimulating them to create the intracellular transcription factor hypoxia-inducible factor, or HIF. Subsequently formed VEGF in turn influences perivascular cells. Perivascular cells are mesenchymal stem cells found on blood vessels. They migrate along the VEGF gradient into areas of low partial oxygen pressure. Here they form new blood vessels that finally integrate into the existing vascular network. Angiogenesis restores the oxygen supply and forms the foundation of bone healing. Starting around day 7, activated osteoclasts attach themselves to the fracture edges of the residual bone, resorbing it and creating space for bone healing. However, this will initially reduce the primary stability of the implant. Here, the osteoclasts dissolve the bone using hydrochloric acid and proteases, releasing BMP, TGF-beta, and PDGF from the bone matrix, which in turn initiate the formation of new bone. Perivascular cells not only create new blood vessels, they also migrate toward existing trabeculae and to the implant surface, where they differentiate into new osteoclasts under the influence of BMPs from the dissolved bone. The adsorbed proteins, such as fibronectin, have a crucial influence on the attachment of bone progenitor cells to the implant surface. The osteoblasts form an organic matrix that is mineralized by incorporating calcium phosphate. Under the optical microscope, bone is visible on the implant surface. Under the electron microscope, though, a thin protein layer is seen between the bone and the titanium surface. Mechanical stability is ensured by interlocking with the surface of the implant. At the end of the first week after surgery, woven bone is formed at the implant surface. This in turn promotes increasing secondary stabilization of the implant, making up for the progressive loss of primary stability. The formation of woven bone concludes the proliferative phase of wound healing. Orderly and coordinated bone remodeling restores the stability of the site. Load adaptation is of pivotal importance in this context. Initially, woven bone will grow in the valleys of the implant surface and parallel to it. After remodeling, most bone will be structured perpendicularly to the peaks of the implant threads at right angles to the implant surface. The architecture and organization of this bone becomes trabecular. The structure is thought to be directly responsive to forces imposed through the implant to the interfacial tissues. This is made possible by the synergy of osteoblasts and osteoclasts. The osteoclasts, activated by the osteoblast messenger rancor, resorb the woven bone. The osteoblasts that lay down highly organized lamellar bone. The work of both cells is mainly coordinated on the osteocyte and its own messengers, such as sclerostin. Lamellar bone structures are formed. Similar to the arches and vaults in the cathedral, they absorb the stresses of our closed load. We are back at an efficient trabecular bone meshwork, perfectly adapted to the new situation. Osseointegration, a highly complex biodynamic process of cell-to-cell communication, is complete.
So, osseointegration is a highly complex process. The good news is that we don't have to do nothing to obtain osseointegration. Osseointegration is a matter of the body, it's a matter of the bone. But the point is that there are some concepts that come from biology that we really need to know. And why is it important? Because biology is always the same. So if we understand a biological concept, we can always use it. Because the time for the biology, for change, for the evolution is too big for us. That's very important because if Giovanni Canino or Omar come in your office and tell you, doctor, I do have the best implant in the world, you have to believe, but ask why. Which is the biological reasons for this. When we find a biological reason, is okay. And biology, remember, is always the same. Try to take out the loadig. I did. So the reality is that our work is very easy. We have to do a hole in the bone and put a screw. I really respect endodontists. They are crazy. They work in a very small area with a microscope, with a lot of crazy stuff. That's difficult. Not to do a hole and to put a screw. And I'm not good at this because when at home there is to put a frame on the wall, I say to my wife, call your father to do this. She get angry because she say, why? You put the screw in the bone, but why don't you put it in the wall? Because it's difficult in the wall. It's very easy in the bone. Let's talk now about immediate loading, And I want to tell you that implantology, or a part of implantology, with immediate loading goes back to its origin. I want to ask you something, because I always do this when I go around in the world to do some conference. Where do you think that implantology was born? In which country? US? Egypt? You mean the very time of pyramid? Maybe. No, a more modern situation. So US or Germany? Japan? Switzerland? Quite close. Someone say, the Bعنوان country, Sweden? No. The modern implantology was born in Italy. And was born in Modena, where I studied. And it was born at the end of 40 by a doctor that was called Dr. Formigini. And what he did was something crazy like that. So it was a wire, and with the end, he twisted to create a spiral and to put in the alveolus. That's it. And I removed in the University of Modena these two implants that worked for 40 years in the mouth of these patients. The Formigini implants. And then we have a market evolution. And we go to needles, blade, and a lot of stuff to an implant that is very close to modern implantology. It's a titanium screw implant. It's another Italian, and once again from Modena, it's Tramonte's implant. And a screw implant with an integrated abutment that represents the extra bone portion. That was the Tramonte implant. And you know what is crazy? In the past, I worked for Nobel Biocare, and in 2004, they called me, and they told me, Professor, doctor at the time, we do have a very, very big news coming from Nobel. I say, tell me, we will choose this big, big news of Nobel Biocare. We invented the one-piece implant. That means that they invented 50 years later the Tramonte implant, the one-piece implant. And these are the first 3 implants I placed maybe in my life, and with a 24 at the time, even more now, years follow-up. So they were Tramonte implant after 24 years of load. Today, I wouldn't use this kind of implants because we have a market evolution, but I won't let you think about what is happening in the world of implantology. And which was the surgical technique at the times? I mean at the time of the crazy Italian, it was very easy. Flapless surgery for implant positioning. You don't open the flap, you go through the ground. Then intraoral abutment preparation, because you have the abutment is there. And of course, immediate loading, because the abutment is there. I will show you. This is no surgery, this is no angle, this is less than acute cleaning. A little bit of aesthetic, and you go to the gown, or you went, we will see. And you prepare there, very easy, no bleeding. First wheel, then the final one. And then you screw the implant in. And the time here, there is no curtain is moving, so it takes 3 minutes to do this. We will talk also about timing of the surgery, because it's also a very important point that usually we don't treat in oral surgery. Any surgical duties, we don't, and we should. So gentle preparation, and then we take our universe implants and we screw it in. No, this is universe implant, IML. But I will have some cases without somebody, don't worry. And then you can take X-ray to see the position, continue to screw. It's very easy, with no bleeding, no panic for the patient, nothing. So X-ray, you go deeper, and that's it. When we did it in the past, which were the clinical advantage of this technique? Minimal surgical trauma, of course, no bleeding, no edema, also edema, short surgical time, immediate cemented temporary prosthesis, the possibility to treat patients for whom would be contraindicated a flap surgery, no periosteal displacement, and we will see how this is important, and the reduction of the expectation of the patient. This is an extra clinical matter, but it's also very, very important. Of course, we do have some disadvantage. No visibility of bone structure needs for a very good primary stability, able to carry out regenerative techniques. And then what happened in modern implantology, going in the direction of nowadays, that we assist to an evolution which is connected with the study of a man I had the opportunity to meet and to know, that is Bعنوان, who got the merit to encode surgical technique and healing times, because at the time of the Italian, everything was crazy. No surgical techniques, no timing, nothing. All was crazy, like the Italian. And Bعنوان said, no, we need a protocol, we need timing, and that's very important. But this is not in relation to clinical evidence. Bعنوان was not a dentist. Do you know this? Was not a dentist. So no any clinical evidence come from Bعنوان. It's orthopedic. And in relation to histological studies, to the optic microscope, and my idea also maybe commercial consideration, because everybody does commercial consideration. Anyway, Bعنوان implants were cylindrical screw implants made of machined smooth titanium, actually smooth, with an abutment that is connected to the implant after a healing period without any load. So for Bعنوان, no load. Load was something terrible, was something to avoid in any way. Is this correct? No. And I will tell you why it's not correct. Let's go back to biology, okay? And to the clip we saw. So what we need, I do some writing. We need, first of all, a trauma. If we want to have a healing, we need a trauma. For example, if we do an extraction, it's a trauma. We will have bleeding, and then we will healing of the bone. When we place an implant, it's the same. We go with the drill, we create a trauma, and we start the process of healing. But what we have in the clip, that the only force that keeps the implant in place when we first put the implant is primary stability. That's it. It's like a screw in the boot. Primary stability. There is no biology there, okay? And then what happens? It happens that there is a cell-to-cell communication. And the cell-to-cell communication is mediated by especially the platelets. Okay? The platelets release some substance that start to create the condition for cell-to-cell communication. Another extremely important thing you see in the video is fibrin, because it creates a network and the cells can stay there. Another aspect is that during the inflammatory phase, the primary stability goes down, because this is a toxic environment, because there are the macrophages that are eating some bone. There are a lot of substances that are trying to clean everything, and in doing this, they reduce the primary stability of the implant. After this, with the vascular endothelial growth factor, especially, start to recreate the network, the blood network, and start to have some healing, start to have some new bone. But always in the video, they told you a very important thing, that when you place the implant and you wait, the bone you have is parallel to the implant. To obtain the standard bone, that means a bone that is perpendicular to the implant, you need load. So please remember, until you don't put the implant under load, you don't have healing. You don't have no healing. It's something in the bone, but it is not in the direction of load, of bite. I will ask you something. You know what? Which is when a man go in the space, on the moon, and go back, which is the disease they come from? Osteoporosis. They all come with osteoporosis. Because of the gravity, the load is lower, and they develop osteoporosis. So we have to reconsider our approach to the load. It's extremely important. On the other hand, Bernard say no. If you want to do implantology, you have to open a big flap, and you have to do a second surgery after 3 or 6 months for the prosthetic phase. Of course, we have a clinical advantage for this because we can see the bone, we can see exactly where we are putting the implant, and we can do regenerative technique, bigger regenerative technique. But the disadvantage are the opposite before. So a great surgical trauma, great post-op edema, prolonged surgical time, you need a second surgery, no fixed temporary. The periostal displacement limit to treat patients who would be contraindicated a flap surgery and increases the expectation of the patient. Because when we increase our surgery, we increase also the expectation of the patient. When we increase the complication of the surgery, we increase the expectation. Let's go now to nowadays. Contemporary implantology say, okay, we can do less invasive surgical technique and we can do fixed prosthesis in a shorter time. But this is something of the last year. You are very young, you don't know this. But when I was young like you, and I went in a congress like that, let's say 20 years ago, and I say, I do loading. Everybody say, no, that's impossible, you can't do it, you are crazy. That's the reality of the past. Nowadays, a lot has changed. This is a picture I did in New York, in the foundation principle of implantology. So, have a look, in 1975, the only principle was primary stability. That's it. And I want to tell you something. They are in US starting from 1975. That means 25 years later than the Italian school. Anyway, in 1985, everything is changed under the pressure of Bernard studies. Because we need biocompatible material, precision fit, passive fit, primary stability, subgingival healing, delayed loading. So this is the standard Bernard implantology. 10 years later, something changed again. Look here, the spot is starting to reduce. What is this? This is subgingival healing. You know why? Because Bernard said, if during the healing period without any load, you see a little bit, the little screw, the cover screw, the implant, you have to do anesthetic to reopen a big flap and to cover everything for healing. That's what Bernard said. And then someone like me, like other doctor, start to think, and if I don't do this, what happens? Nothing. That's why it's reducing. Nothing. It works the same. And that's why in 2005, everything is changed again. And we are talking about a lot of years ago, because the only two very important points are biocompatible material and primary stability. So let's say its primary stability is the only thing that in all this year remain very, very important for the biological reasons I told you and I showed you in the clip. So now the point is, it can be difficult to choose between which approach we should have. Immediate loading, delayed loading. I know. The bad news is that there is no a single approach. I mean, you can't do always immediate loading, and you shouldn't do always delayed loading. So we have to take care about some point and understand when it's the one or when we have to apply the other one. And what we have to take care of course, the clinical and general situation, but also the clinical general condition. Because if I have, for example, a patient for whom it would be contraindicated a flap surgery, I have to understand if if I can do it without flap, for example. Another aspect, the age. The age is very important because age means two things. One is the quality of the biological response, and the second one is life perspective. What does it mean? You know which is my success, for example, in the treatment with implant of the agency sigle. It's quite common in Italy, especially in a female. And I do have in my clinic a lot of patients, 18, 19 years old, where I go, especially female, I go and place an implant in place of a missing lateral. My success rate there is 100%. Not because I'm good when I work with young ladies. The point is that biological response is great. Everything is great there for healing because we are talking about very young patients. But the reality is that the nature of our implantology is in older patients and very often in patients with no very good general condition. So we don't have to think, we have to think outside the box. So implantology is not always the same. It's one story if I treat a very young man or female, another story if I treat a older one. Because we have to read the age also in terms of life perspective. Because if I'm treating a 80 years old patient, I hope for him I will remain this bridge work a lot of time. But maybe it won't happen because your perspective of life is not so long. That means that you can do some compromise, you can do an easier surgery in consideration of this. Another point, smoking. I want to ask you another question. Do you think that smoking is a problem for osseointegration or not? Okay, so most of you think that smoking is a problem for osseointegration. It's not. It's not at all. There is no any big study that shows this. On the other hand, there are two very powerful publications. One for a good friend of mine, that is George Romanos, and another one for another good friend, that is Dennis Tarnow. There are two big balls of implantology in the US, and they demonstrate with a big number of cases that smoking is not a problem for osseointegration. This is a legend for the dentist legend. I will ask you another thing. When you break a arm or a leg, you go to the orthopedic, you put the gypsum. You will never hear an orthopedic tell you, wait, don't smoke during this period. Never. Why? Because it's not a problem. But on the other hand, smoking is a problem for soft tissue healing. So once again, are we treating a patient, opening a big flap, a smoking patient, opening a big flap is a story. Are we treating a patient without a big flap is another story. Then, of course, we have to take care about the kind of processes we have to support. On the other column, there are extra clinical points. Economical situation of the patient. We have to put in relation, which is the power to spend money of the patient with what we propose to the patient. The hypnosis have to be only one, but therapy can be different. And we have to put in relation with the money of the patient and also with the time of the patient, because sometimes patients have money but don't have time. And aspects, aesthetic needs of the patient. So we really have to, when we have a patient on the chair, we have to think all this parameter to understand which is the better therapy for our patient. Another thing, the patients are not interested in implants of face, connection, and a lot of things that we care. That's a dentist problem. The patient don't want implants. Remember this. The patient wants teeth, not implants. And immediately, they want teeth immediately to replace the one subject to extraction, aesthetically good and acceptable in terms of money and time. So this one are the core of the patient. And immediate loading and post-extractive immediate loading are the gold standard to obtain this objective. That's very important key point, because if you go in the direction of your patient desire, you will be a successful dentist, because you are doing what your patient is asking to do. We have also to consider that immediate load gives the best maturation of soft tissue, because it is procedurally driven in post-extractive case, of course. Another aspect, the use of osteoblastic activity of alveolar bone after extraction is very, very big, bigger than normal bone. Do you know why? When you do an extraction, your body really wants to heal. Why? Why the body is biological, very smart, want to heal very fast when you do an extraction? Very good. Yeah, you have to close the wound. Why? Because on the other hand, you die. They say you are crazy, for extraction you die. Okay, not today, but think 100 years before, without antibiotics, is an open wound in the mouth full of bacteria. You can die. And as I told you before, biology is very slow. So it takes time to change the biological mechanism. That's why when you do extraction and you place an implant at the same time, you can achieve a very important result. Then you can avoid the removal process. Removal processes are a big disaster for implants. Why? Because, once again, biology, all the vascularization or the majority of the vascularization of the bone come from periosteum, not from the inside the bone. That means that you put a removal on the periosteum, you press the periosteum, you will have a compression, no blood support, and you will lose a lot of implant. You think you do it better because you say, okay, I do like Brian, I leave it there for 3 months in the mandible, with a removal home, I'm sure one you will lose. And the other aspect is the prevention of post-extractive resorption. So, I prefer immediate loading if I do have a good quality of bone and a good primary stability. If I do have multiple implants, it's even better, because at time zero, you can work also with a non-passive structure. And on the other hand, you have to do this when the patient doesn't accept the idea of using a removal prosthesis. When I start working, why I had a very good result in my office? Because 20 years or more than 20 years ago, the patient came in my office and told me, "Doctor, I went in the office and they told me I have to do extraction, I have to wear a removal for 4 to 6 months, then I will place implant, and after other 6 months, I will have a temporary. So in 1 year, I will have a fixed process." And I told them, we can do it in 1 day. And I started to do this with good success, and I will explain in the 3rd day how to manage these more difficult cases. And this made a big difference because that patient didn't want to wear a removal for 1 year. And of course, it's also very useful if I do a post-extractive flapper surgery to keep the gingival and bone structure. But I still do of course, delay the loading. If I have to do an implant and I don't have a very good primary stability, or also if there is no specific aesthetic needs and the patient can avoid a removal. I mean, if a patient comes in the office and to put a lower molar missing from 5 years, there is no reason for me to run and to put a crown. I will put a healing abutment, and after 3 months I will put a crown. The loading approach, so is not easy and must be supported by scientific evidence as we see, and common sense. Also, common sense is very important in surgery. I saw in my life a lot of very, very good surgery without any common sense. It doesn't work. I prefer the first common sense and then do surgery. And anyway, we have to be lucky in life. I'm sorry for this picture. We do this in Italy. I know in the rest of the world, you touch wood or touch iron when you don't want to have bad luck. And we do this in Italy. So let's go now to the clinic. And we will see during these 3 lessons the clinical experience, starting from single tooth to multiple implants to full arch rehabilitation. To be honest, the most easy one is this, is the full arch. And I will tell you how to manage it in a very easy way, a full arch rehabilitation with implants. Single is not so easy, maybe it's the hardest, but for a didactic point of view, it's better to start from single. And let's see a single tooth post-extracted immediate loading in a bacterial compromised sites. So this was at the time a 40 years old female with odontopathy, good general condition. She wants, like every patient, a rabbit theory. So here is the patient, fistula here, no bone. So this is of course a hopeless crown. So what I do with this patient is on the chair. I say, okay, madam, all we have to do here is extraction and socket preservation. We wait for 6 months. Then we put the implants. We wait for other 6 months. And then you will have the crown. Is it correct? After I say this, and the patient is shocked like that because he starts to think, wow, 1 year to replace this crown. I say, or, and I stop. Pardon? Socket preservation, yeah, bone graft. That's why we wait 6 months and then. So I explain all this to the patient. So extraction, bone graft, and waiting an implant. After extraction method. I will show you the technique of how to manage this. After I say this, I say or. The patient look and say or we can do it all in 1 day. An extraction, I put the implant, I put a temporary crown. And all my patients say, doctor, do this for me. I say, yeah, I know, I can, but you know, it's a little bit risky. Because if we do like I told you before, I'm more sure that it will work. This is a little bit risky. And the patient asks me, which is the risk? I say, if we do have a problem, we go back with the other technique. So any patient in my life told me, please do immediate loading for me. The interesting point is we are sharing with the patient the risk, the responsibility. Because I already tell the patient, listen, we can have problem. And if we have problem, that's what we will do. So everything is very clear for everybody. The reality is that it's very difficult to have problem if you do it the proper way. So, extraction, implant site preparation, implant insertion, abutment insertion, acrylic crown to obtain the correct gingival margin, and sometimes to keep the graft material inside. So here is the patient, and Look here, there's a little blue spot. This is time 0 surgery. Why there is a little blue spot? Because when we talk about immediate loading, it's not everything. We have to make some difference. And a classification I like is the one from the Gigli and Fratelli, and they say we have to make a difference. Early loading, immediate non-function loading, immediate function loading. So early loading means the final crown, the ceramic crown, 3 weeks from in occlusion. That's for crazy man. Why? If you remember biology, I told you, primary stability, all the first month go down. That means that you put under load or under a stronger load at 3 weeks, you are crazy. Because it's the worst moment to place the implant on the road. So we have to focus our attention on immediate non-function loading and immediate functional. Non-function means the temporary, the same day of surgery, not the occlusion. The other one is the temporary, the same day of the surgery, in occlusion. Of course, the first feeling everybody can have is, okay, don't put in occlusion, maybe it's better. No, it's not correct. What was featured to me by George Romanos was this: the temporary, the same day in occlusion. There is a sort of trick for this, and I will tell you this. Why? Which is the problem? If I think to do this, what happened is that I put my implant like that, I put my crown in my lab or myself. I will do a beautiful premolar with 2 very big and long caskets. And when I ask the patient to close, there is some space from the crown, the temporary crown, and the opposite tooth. So I think, wow, I'm safe. I can't have a problem because there is no touching. That patient finishes the surgery, goes down to the bar, take a very nice sandwich, very thin sandwich, put in the mouth, and everything is going bad because the two crystals are working like that, are giving a lateral forces to the implant, and you will lose that crown. And you made a mistake because you think there's no occlusion, I'm safe. That's why I prefer this. That doesn't mean I give a strong occlusion, but that means I think to the occlusion. So I ask the patient to close, to go forward, to go laterally, stand up, okay, we'll walk in the office, sit down again, let's check again. And at the end, if you want, take everything out, all the blue points or red point up, it's okay. But you studied the occlusion and you take care of the occlusion. But in any way, we need primary stability. Here is once again the patient, and just for economical reasons, not for other reasons. After 1 year, she still had the temporary crown, the soft crown. So this is the time 0. This is 1 year after load with let's say a very gentle load. But what is interesting here are these two pictures. And why? Because when I put the crown here, the metallic crown, the ceramic crown, and the load is stronger, the bone is going better. So this is 1 year, look where the bone here, and this is after with a stronger load. So once again, we have to reconsider the power and the opportunity of load. And this is the same patient after 15 years. Let's see another case. 33 years old, good general condition, 25, looks not bad here, but look, big fistula, part of fistula. So the same story. So madam, the therapy is extraction, socket preservation, waiting for 6 months, put an implant, waiting for us, put the crown. Or, and they always do all for me. So, look, the fistula coming from the palatal, going here, the implant, the abutment, and here is the day of the surgery. Here is 1 week later. Look, the fistula is going to disappear. And here is 9 years post-surgery. Another one is a funny story because this man is a lawyer, is a attorney, and I did to him in the past, a long time ago, did this work, really loadig. And then you get this canine broken, but in this 20 years, you become one of the most dangerous attorney in my city. So he went with this crown broken and told me, listen, I want to do like the last time we did the immediate loading, and please take out the canine and put another one. So I was scared because now it was a very powerful lawyer, attorney. I said, you know what, maybe it's better to do the removal, waiting for a little, and no, I want to do it now, believe me now. Then put the hand in the pocket and take out a lot of money. Boom. I say, okay, we can do it. So sometimes the protocol can change for several reasons. One is money. I'm joking, of course. So what I did here, I do a gentle extraction of a fractured canine. It also endo, so it's not so easy to do extraction. You know this, of this kind of root without damaging everything. That's why I'm using piezo here to obtain this. And then I will prepare the site with piezo, and I put my universe implant, my abutment, and my crown. So here is the root. Then I go with the preparation, with the piezo. Piezo is very good to prepare in post-extractive sites. I don't like to prepare with piezo in standard bone, in normal bone, but in post-extractive site it's very good because it's very easy to change the position, the angulation, and to increase also the density of the bone. Magnetic mallet is a good instrument. I don't have experience with direct experience because I prefer piezo. They are quite similar like concept. The main difference is with piezo, I still have live osteocytes on the cut surface. That means when I cut the bone with the piezo, I still have live cells on the bone. With magnetic mallet, it works like a osteotome, so if you squeeze the osteocyte, it dies. So it's quite similar, it's faster, the magnetic mallet, and that's a good point. It's more gentle than piezo. So it depends if you want to be faster or if you want to be more gentle. But are two very good equipment anyway. This position? No, this is only ultrasonic preparation and then a implantation. That's it. It's very easy when you do extraction and you do this. If you try and do on bone without extraction, it's not good. So I check also the torque of my implant, and then I put the abutment. I choose the abutment. I will show you also to manage the abutment, and then I put the crown. So here is the universe implant with the abutment, and here is the crown. Look here. At the end, there is space here. So I don't want you to misunderstand me. But why there is space? Because after I try all the movements, I decide to do this. But you have to try all the movements. Because if you leave a little bit longer and you don't try the movement, it's not enough. And let's increase the difficulty, because here we do have a single tooth, but also a graft. 1/3 of the implant is out of the bone. So, of course, in this case, I have to open, flap the bone, the membrane, and I put my temporary. This is 5 years post-load, and this is more interesting because this is the three-dimensional. So all this area where I didn't have bone, I do have bone. And once again, why did you put on the load? Because the stability was good, and the load give the information to the bone to become bone. Otherwise, there is no any information. This is a sapphire implant. This is a sapphire implant. Sapphire. Sapphire is, I really like in the upper jaw. In the lower universe is the top, also the upper, of course. But sometimes sapphire is very, very good in the upper. Another case, more difficult. Look here, big fistula here, hopeless, and no bone, no buccal bone. Do I need a CT scan to understand this? No, because you take the probe, you put in, and the gum is moving. That means there is no bone. Or you can do like that and see directly. And what I do here, all the story you know, the patient say, but in this case, this is a very, very hard case. I ask help to biology. So what I did, I use like graft material, this one. This is concentrated growth factor. That means I take some blood from the patient, I put in a dedicated machine, and what I obtain this one, and this is fibrin. If you remember the movie, the first component is fibrin to create the network to stop the cells. All the fibrin is there. And what do I have inside this fibrin? I do have platelet. That means the platelet drives the growth factor. So growth factor. I do have stem cells. I do have BNP. So all the components that biology needs for healing are concentrated there. So I'm putting a booster to biology. And you just have to put in the virus. That's it. Look, all the part is missing the bone. When you see the resin, of course, we grind it, we polish it very, very much. Look, as I put the graft, the CGF inside, the fiber inside, look, the fistula is even bigger now because it's pressed by the CGF. And here is the patient 2 years later. Looks good, but doesn't make sense, this X-ray, because I can have a good distal good means no buccal bone. The X-ray is the same. And okay, the clinic tell me it's working, no bleeding, no everything is good. The panoramic is the same story. It doesn't make sense, but look here. For me, this is an amazing picture. You know why? Do you know what is this? Bone. That one is human cortical bone. That means that this is a regeneration. This is not a reparation. Regeneration and reparation are two different mechanisms. If I put any graft material, maybe also autogenous bone, it's very, very hard to obtain a regeneration. You always obtain reparation with graft material. With the concentrated growth factor, you can have a regeneration, a restitution integral. That one is human cortical bone. Let's see 2 or 3 other cases and then we'll finish for today. And in this case, is no more bacterial compromised site. This is not a bacterial, this is a dimensional compromised site. So I don't have enough bone. There's a leaky canine and impacted permanent canine. So here is the situation. And once again, the concept, the very important concept, is that the diagnosis is one, but the therapy can be a lot. And what I do, I discuss with my patient, and I say, listen, you can do here a medial bridge, a standard bridge, a removal. You can do ortho surgery to take it out. We can take it out, waiting and put an implant. We can take it out and put an implant at the same time. A lot of stuff. And then I decide with the patient which is the best therapy for her. What we decide here, she wants something very easy, very soft surgery. And what we did, we use growth factor once again, and we use a very short implant with immediate loading. This is a 4/8 implant in the canine area with immediate loading. And this is 2 years later. But the same case, impacted canine, with milky canine, in a younger patient can be treated in a completely different way. In fact, what we decided to do here was the extraction of the impacted canine, the use of growth factor, and we place a starfly implant with immediate loading. So I use the pixel here to preserve as much bone as possible and to create a very good surface to obtain the graft, to keep my graft. Because as I was telling to Dr. Canino, the good of piezo is that it creates a porous surface that is very good for the fiber to drink. And it's similar to implant, this is CGF. When you do a restoration and we do some itching agent on the eminence, it's the same. Yeah, correct. So I prepare also this case with piezo because it was very few bone and I want to increase primary stability and change a little bit the consistency of the bone. And I put the CGF or PRP, we can call it, inside, like the only graft material. That means that it's very safe, it's biological, it's very powerful, and it's also very cheap and very easy to be managed. It's for free, so I put a lot because it's free. I wouldn't do it with bios the same. But the reality is that with bios, I will never have bone. Yeah. So then I screw the implant in, and then I put a battlement, and I put the battlement in the crown. So this is the situation, and I want to show you something. For me, this picture is great. That one is the eating after 1 week. If you look both sides, you can understand which one did the surgery. Okay, you understand for the notes, otherwise you can't understand. And that's the power of give you a very fast and good healing. And here is the patient X-ray before the final restoration. And here's the final restoration with the final crown. There is a technique also to have a very good position. I will show you quickly. To take an impression, and before doing everything, in the stone model you prepare a hole. Then you do your implant, and then you can create an index with the resin in the adjacent teeth. And after you do all the surgery, you can create the jig in the mouth of the patient and replace in the model you did it before. So you put some Duralite resin and you have the position of the implant, and you can work outside the mouth of the patient to obtain the right abutment. And then you can also scan or do an impression for the final restoration. But we will go back in case to this in another time. Because I want to finish with a case, also to give you some fun, to make you laugh. And also to explain you a very important concept. So you will have time to think about it, and tomorrow we can discuss again about this. The funny thing is that this patient is my mother-in-law, is my amati. And I did this wonderful work for her. And I say, Mama, that's perfect. After a little bit, she's a clever woman. She told me, Andrea, if you want to go out on Saturday and I keep your voice, you have to do something for me. I understand. You know, now we invented implant, I say. So we will do implant. So this is my mother-in-law. I'm taking the blood. I'm taking for here because it is more painful. This is only for amati. For standard patient, take from here. Okay? So I put in the machine, and after taking out the molding, I go with piezo and I do the extraction without anesthesia, of course. Has to be cheap. But what I really did to be cheap is to use one piece implant, of course, not by the attachment. So the gentle extraction will serve as much more as possible, and to have for cavitational effect also the contamination of the site, then the preparation of the site. And here is like poison, you have to be very careful with the blood. This is PPP, the first part, the poor platelet plasma, and here is the fibrin, and we have inside all the things you know: growth factor, stem cells, and BMP and circulating antibodies. So what we can easily do without opening the flap, just placing it in the alveolus. So here is the PPP. We can use it to wash the alveolus and to do some mesotherapy, because we do have a lot of antibodies there, and circulating antibodies, and also we do have some cytokines and leukocytes. And then I screw the one implant abutment, of course, in, and you will see that on the other side, I take the fibrin, just put it in, and this was a whole style. I will show you the model style we developed with IML to do this. And the last publication was admitted yesterday for the publication about this. So I screwed the implant in, one is implant. I check for the torque. Of course, the difficult part here is to obtain a right parallelism, but that's it. And that morning, I was quite late. So I just to cement the temporary, but I went to do something different. But when I went back to cement temporary, I was quite shocked, because look, this is the patient 1 hour and a half later. If you remember, it was yellow, it changed color. It's similar to gum after 1 hour and a half. That's biology, the power of biology. And what I did here, but is only a mother-in-law protocol, I put the crown under load after 1 month. So impression, crown under loads, and don't do it at home, please. Because as I told you, and as the biology told us, the primary stability goes down all the first 3 weeks, always. In the secondary stability, the biological stability or osseointegration, it doesn't start before 3 weeks. In any way, or maybe there is also an exception. I will tell you the third day. So this is my mother-in-law after 1 year, after 3 years, 5 years, I put more and more implant, now more implant. She's still alive and continues to put implant. Doesn't matter. So I will finish giving some very important concepts. First of all, a question. When I do extraction, implant, should I do a very good debridement? Should I clean very, very good everything? Someone say no, someone say yes. In fact, the answer is in the middle. I mean, we need to clear, but no hard debridement. Because what we know from literature, for all literature, 2003, is the retention of PDL, support retention of cloth, and support the healing process. Cardaropoli, Araio, Link. This is part of the reality. This is true, but the reality is not the retention of PDL support the cloth. There is another story for this, and I will tell you in 2 minutes. Another point, Araio, 2 years later, did a demonstration that say, if you do an extraction and you place an implant, you will lose bone, especially buckling. And Araio thought this is related to disappearance of the bundle bone and also disruption of the blood supply due to generation of plaque. So, first point, and we will go back to this point. The surgery and the healing is completely different if you open the flap or if you don't open the flap. There are two different patterns of healing. And Araio say, no, listen, if you do this, you lose bone. No way. But after some year, in 2010, Adler introduced a technique I anticipate you, I don't like. And this technique is the socket shield. I mean, he said, instead of doing an extraction, a full extraction, we leave a little part of the root here, and this will keep the buccal bone. So if you leave a little part, you can see the storage of the residual root of the crown, you won't lose the buccal bone. So the question is, and this works, that's true, why does this happen? Which is the biological reason for this? The biological reasons is BMP. The point is, what is in the ligament, in the PDL, are BMP. That means bone morphologic proteins. Bone morphologic proteins are extremely important to recreate and to formate bone. And what happens in our body is that there is an equilibrium in between BMP that produce bone and anti-BMP that stay in the gum, in the soft tissue, that fight against BMP. In between this equilibrium, we can keep bone. That's why you can see a CT scan, and each of you know this. Sometimes you see the canine, the upper canine, that look outside of the bone. A very, very thin layer of bone, or the central incisor, the same. Why you keep that bone and you lose with an implant? Because you do have the PDL in the normal crown, in the normal root. And in PDL, there is the BMP. That's why the anti-BMP can't destroy the bone. So all the story is the equilibrium between BMP and anti-BMP. I think a lot of you, a patient came in the office and told you, look, doctor, here I got something strange, something like bone, here in mind. And we said, no, don't worry, this is a talus, isostosis. Don't worry, it's nothing. All these are isostosis, and this equilibrium in between BMP and anti-BMP. There are about 20 in our body because it works also with the skin. Also in the skin, we do have anti-BMP for the bone, for the skeleton. And the most important for us are BMP 2, 4, and 6. And look, this is an experiment we did in UK, and this is osteoblast without BMP. This is osteoblast plus BMP is a party. So osteoblasts are crazy for BMP. So we do have the gum that are inhibiting BMP and the ligaments that are pushing the BMP. And this is the equilibrium. That ones are the inhibitory audience calling for a lot. So the point is, gingival produce factor which strongly inhibit bone formation in vitro by the production of BMP inhibitors. This effect can be reduced by the addition of BMP. Of course, yes. That's why we don't need to do a severe debridement, because we want to use the BMP there. And I will let you with the last consideration. When we put a membrane, they teach in university, also to me, also to you. We open the flap, we put a graft, and we put a membrane to protect the graft from what? From the epithelial cells. It's not true. It's not true at all. Because if you take epithelial cells and you put in the bone, you will die. Come the marrow and eat. When we put the membrane, it's a chemical barrier for the anti-BMP inhibitors. So we have also to change this paradigm we have for a long time. So thank you very much for your kind attention.
كله